Hello students. Today we will be discussing about generalized anxiety disorder and panic disorder. Firstly, to begin, anxiety is characterized by unpleasant emotions and cognitions that are future-oriented and is a much more complex response pattern when compared to fear. While fear is merely a reaction to immediate danger, anxiety is a blend of physiological, cognitive, as well as behavioral components. At a physiological level, anxiety is often a chronic state of tension and arousal where the sympathetic nervous system is active. The cognitive components contribute in including negative mood, worry about possible threats or danger in the future, and a sense of uncertainty about the future, which are often followed by risk assessment behaviors of readiness and constant alertness to deal with anticipated dangers. Though the physiological responses in both anxiety and fear involve the sympathetic nervous system, in anxiety there is a fear of the anticipated, whereas the response to fear is more immediate and includes a series of fight or flight responses. However, anxiety can be adaptive and help individuals to notice and plan for the potential threats that one might face in the future, aiding the individual to increase his or her preparedness about a particular event, help them avoid potentially dangerous situations, and think through potential problems before facing them. Now, I would like you to see the diagram presented. The anxiety disorders according to DSM-5 are presented here. Separation anxiety disorder, selective mutism, specific phobia, social anxiety disorder, also known as social phobia, panic disorder, agoraphobia, and generalized anxiety disorder. The International Classification of Diseases 10, ICD-10, lists generalized anxiety disorder as a disorder subcategorized under anxiety disorders and broadly categorized under neurotic, stress-related, and somatoform disorders. ICD-10 lists panic disorder with agoraphobia as a specification, panic disorder with agoraphobia, and panic disorder without agoraphobia under the subsection of phobic anxiety disorder. Now, let's see the global as well as the national prevalence of anxiety disorders. Anxiety disorders are the 6th leading cause of disability worldwide, and the global statistics of prevalence of anxiety disorders is roughly 273 million. Anxiety disorders, particularly panic and general anxiety disorders, are more commonly reported in the Western societies than in the non-Western societies. When compared to the other anxiety disorders, panic disorder does not record to have a high prevalence. However, GAD, that is generalized anxiety disorder, is reported to affect 4.3% of the world's population. It should be noted that factors associated with panic disorder and GAD overlap more strongly with those specific to anxiety disorders than other mental disorders. The extensive study done on the prevalence and incidence rates of anxiety disorders in our country by the National Mental Health Survey of India reported the prevalence of panic disorder and anxiety disorder as 0.5 and 0.6% respectively. The study also reported that the generalized anxiety disorder is highly prevalent among females than males, which remains the same even in the global scenario. Now, we will be dealing with generalized anxiety disorder in depth. We will be seeing the symptomatology, the etiology, and the treatment procedures for generalized anxiety disorder. Starting off, generalized anxiety disorder, formerly known as free-floating anxiety, is characterized by an excessive and inappropriate worrying that is persistent and not restricted to particular situations. Individuals with generalized anxiety disorder have physical anxiety symptoms such as tachycardia and tremors, and key psychological symptoms including restlessness, fatigue, difficulty in concentrating, irritability, muscle tension, disturbed sleep, and so on and so forth. The diagnostic criteria for generalized anxiety disorder according to DSM-5 is as follows: excessive anxiety and worry, apprehension, expectation, occurring more days than not for at least 6 months about a number of events or activities. The individual finds it difficult to control the worry. The anxiety and worry are associated with 3 of the following 6 symptoms. First, restlessness or feeling keyed up or on the edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, sleep disturbances, that is difficulty falling asleep or staying asleep, or restless unsatisfied sleep. Then the anxiety, worry or physical symptoms cause clinical significant distress or impairment in social, occupational or other important areas of functioning. This disturbance should not be attributable to physiological effects of a substance or another medical condition. The disturbance is not better accounted for by another mental disorder. The factor that determines whether individuals with a genetic risk for GAD seem to be the specific non-shared environmental experiences faced by the individual. It appears that highly anxious people have a kind of functional deficiency in GABA, that is a neurotransmitter, which ordinarily plays an important role in the way our brain inhibits anxiety in stressful situations. More recently, researchers have discovered that another transmitter, serotonin, is also involved in modulating generalized anxiety disorder. Research suggests that the neurotransmitter GABA, serotonin, and perhaps norepinephrine all play a role in anxiety. Moving on to the psychological causal factors, the psychoanalytical viewpoint holds that the symptoms of generalized anxiety disorder develop due to the unconscious conflict between the ego and the impulses. According to Freud, when the sexual and aggressive impulses have been blocked from being expressed as a result of punishment, prolonged deprivation, or other environmental factors, this can lead to developing generalized anxiety disorder. Experiencing uncontrollable and unpredictable aversive situations can induce stress, and people with generalized anxiety disorder, most often than not, have a history of experiencing most important events in their lives which were unpredictable or uncontrollable. Yet another psychological explanation of generalized anxiety disorder could be the tolerance for uncertainty. A research study has shown individuals with generalized anxiety disorder having less tolerance for uncertainty than non-anxious controls. This low tolerance for uncertainty in people with generalized anxiety disorder can be attributed to these individuals being disturbed by their inability to predict the future. Thus, an individual's idea and history of control in terms of aspects related to his or her own environment determines and affects his or her reactions to anxiety-provoking situations. Now that we know that the process of worry is considered the central feature of generalized anxiety disorder, it is important to know what people with generalized anxiety disorder think of the benefits of these worrying thoughts and what these worrying thoughts serve them as. Several of the benefits that people with generalized anxiety disorder most commonly think derive from worrying are superstitious avoidance of catastrophe, avoidance of deeper emotional topics, coping and preparation. Moving on, we shall see the treatment plans for generalized anxiety disorder. Firstly, pharmacotherapy. Persons with generalized anxiety disorder consult family physicians seeking relief for their anxieties, often attributing it to their various functional or physical problems. However, they do not work effectively on worry and other psychological symptoms related to generalized anxiety disorder. Moreover, these medications can create physiological and psychological dependence, and withdrawal symptoms can occur too. Involves a combination of behavioral techniques such as training in applied muscle relaxation and cognitive restructuring techniques aimed at reducing cognitive distortions and information processing biases associated with generalized anxiety disorder, as well as reducing catastrophizing about minor events. Yet, another psychological technique commonly used to treat generalized anxiety disorder other than CBT is relaxation training. The idea behind relaxation training is that the relaxation of the physical body will lead to a state of psychological relaxation. Psychologists or therapists teach their clients to identify individual muscle groups and consciously tense these muscle groups and release the tension, which ultimately relaxes the whole body. On practice, clients can bring on a state of deep muscle relaxation and reduce their state of anxiety. Research also indicates that relaxation training is more effective than no treatment or placebo treatment in cases of generalized anxiety disorder. Also, the other techniques that are known to relax people with generalized anxiety disorder, such as basic meditation, often seems to be equally effective. Biofeedback is another technique where the therapists use electrical signals from the body to train people to control physiological processes such as heart rate or muscle tension. In this, clients are connected to a monitor that gives them continuous information about their bodily activities. The device then converts the electrical energy coming from the muscles into an image, such as lines on the screen, or into a tone whose pitch changes along with changes in the muscle tension. Thus, clients see or hear when their muscles are becoming more or less tense. The clients attend to the signals from the monitor, and they gradually may learn to control even the involuntary physiological processes. Through repeated trial and error, the individual becomes skilled at voluntarily reducing muscle tension and thus applying the same skill to reduce tensions and anxieties in various stressful situations in their day-to-day lives. Now, we will be discussing about our second disorder, panic disorder. Panic disorder is characterized by recurrent individual and unexpected experiences of panic attacks. Individuals having panic disorder are persistently concerned or worried about having more panic attacks. What are these panic attacks? Panic attacks are abrupt surges of intense fear or intense discomfort that reach a peak within minutes, accompanied by physiological and or cognitive symptoms. The diagnostic criteria for panic disorder, according to DSM-5, is as follows. Recurrent unexpected panic attacks, that is, a panic attack, as we've discussed earlier, is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time 4 of the following symptoms should occur. The symptoms are palpitations, pounding heart or accelerated heart rate, sweating, trembling or shaking, shortness of breath or smothering, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, chills or heat sensations, paresthesias, that is numbness or tingling sensation, depersonalization and derealization, fear of losing control or fear of dying. At least one of the attacks has been followed by 1 month or more of one or both of the following, that is, persistent concern or worry about additional panic attacks or their consequences, example losing control, having a heart attack, going crazy, a significant maladaptive change in behavior related to these attacks. For example, behaviors designed to avoid having panic attacks, such as avoidance of exercise or unfamiliar situations. The disturbance is not attributable to the physiological effects of a substance, example, a drug or medication, or another medical condition, such as hypothyroidism or cardiopulmonary disorders. The disturbance is not better explained by another mental disorder. This is when we say that a person fulfills the criteria of having a panic disorder. Moving on, we shall see the etiology or the causes of panic disorder. Firstly, the biological causal factors. The heritability component of panic disorder, as reported by various family as well as twin studies, have been moderate. Recent research has identified the specific genetic polymorphisms that can cause panic attacks solely or when in interaction with certain stressful events faced by an individual in his or her lifetime. Such studies must be replicated to draw any further generalizations about the findings. Nevertheless, a genetic vulnerability for developing panic disorder can be manifested at a psychological level through the trait of neuroticism. Those individuals who have a history of phobias, be it social or specific phobia, are at a higher risk of developing panic disorders. However, we cannot draw conclusions as there is a dearth of studies in this research area. The amygdala is to be understood as a part of the brain which is the center of emotions. It is critically involved in the emotion of fear. The amygdala is a collection of nuclei. By nuclei, I mean a specific collection of structures in the brain which is located in the front of the hippocampus in the limbic system of the brain. Stimulating the central nucleus of the amygdala stimulates the locus coeruleus, that is, a structure in the brain stem where the neurotransmitter norepinephrine plays a central role, which in turn stimulates the autonomic nervous system and the neuroendocrines, which in turn stimulates the autonomic nervous system, the neuroendocrine, as well as the behavioral responses that occur during a panic attack. Other researchers suggest that along with its connections with the lower areas in the brain, amygdala is also connected to the higher brain areas such as the prefrontal cortex. Thus, the amygdala plays a central role in the fear network of the brain, which can be activated either by cortical inputs or by inputs from the lower brain areas during a panic attack. According to this theory, panic disorders are most likely to occur in individuals who have an abnormally and highly sensitive fear network. That is, individuals who show heightened startle responses to loud noise stimuli and slower habituation to such responses. These abnormally sensitive fear networks may be partially heritable, but may also develop as a result of repeated stressful life experiences, particularly those which are encountered early in an individual's life. Biochemical abnormalities have suggested that these abnormalities put a lot of stress on certain neurobiological systems which in turn produce intense physical symptoms of arousal, such as increased heart rate, respiration, or blood pressure. The theory of the inhibitory neurotransmitter, GABA, in the brain, which is known to inhibit anxiety, has been shown to be abnormally low in certain parts of the cortex in people suffering with panic disorder. Being panic prone can be a major psychological contributor to panic disorder, as people who are panic prone may be very sensitive to certain bodily sensations. When experiencing any such sensations, they often misinterpret them as signs of a medical catastrophe. Thus, misinterpreting and overemphasizing on every detail in their day-to-day lives, many situations and sensations are viewed as increasingly upsetting and losing control. They are also convinced and believe that these sensations will return at any given point of time or in any particular events, thus avoiding such situations to avoid further panic attacks. A learning theory of panic disorder that accounts for most of the known findings about panic disorder says that the internal body sensations of anxiety or arousal, such as heart palpitations, effectively become interoceptive conditioned stimuli associated with higher levels of anxiety or arousal. According to this theory, initial panic attacks become associated with initial neutral internal and external cues through an interoceptive conditioning. One primary effect of this conditioning is that anxiety becomes conditioned to these conditioned stimuli, and the more intense the panic attack, the more robust the conditioning that will occur. Thus, this conditioning of anxiety to internal or external cues associated with panic thus leads to the other components of the anticipatory anxiety. Moreover, a recent study demonstrated that once an individual has developed panic disorder, they show greater generalization of conditioned responses to other similar cues than do the participants in the control group without panic disorder. Starting off with the pharmacotherapy, anti-anxiety medication are prescribed for people with panic disorder, and other medication from the benzodiazepine category can also be prescribed. The other category of medication that is useful in the treatment of panic disorder are antidepressants. When compared to benzodiazepines, these do not create a physiological dependence, and they also aid in alleviating any comorbid depressive symptom or disorders. One of the most widely used techniques involves the variant on exposure known as interoceptive exposure, that is, deliberately exposing an individual with panic disorder to feared internal sensations. This was adopted considering that the fear of these internal sensations should be treated in the same way the fear of external agoraphobic situations are treated, namely through prolonged exposure to those internal sensations so that the fear may extinguish. The second set of techniques are often called the cognitive restructuring techniques, which state that catastrophic automatic thoughts may help maintain and make panic attacks recur. One of these techniques, which is effective in treating panic disorder, is the panic control treatment, or also known as PCT. Initially, in PCT, the clients are educated about the nature of anxiety and panic and how the capacity to experience both is adaptive. Secondly, the treatment involves teaching the clients with panic disorder to control their breathing. As the third step, clients are taught about the logical errors that people with panic disorders are prone to make and are taught to subject their own automatic non-rational thoughts to a logical reanalysis. Finally, they are exposed to feared situations and feared bodily sensations to build up a tolerance to the discomfort. Generally, the magnitude of improvement is often greater with these cognitive and behavioral treatments. Moreover, these treatments have been extended and shown to be very useful in treating people who have nocturnal panic. However, combined treatment, that is, combining cognitive behavioral therapies with pharmacotherapy, can usually prove to produce a slightly superior result compared to either type of treatments alone. In this module, we have learnt about generalized anxiety disorder and panic disorder. In the modules to come, we shall see in depth about the various other anxiety disorders. Thank you.